Good morning. One of the things we like to do here at UWA is try and get our lectures underway promptly. So I think we'll get started now, and for those of you who are here, I'll reward you. Thank you for coming along. This is me. I'm Jeff Hamdorf. I'm a professor of surgical education, and I'm a surgeon. I work in the Faculty of Health and Medical Sciences here at the university and have done so for some time. Can we just get a feel for who you are? How many people are already at university doing an undergraduate degree? Yeah, school students? Years 10, 11, 12, parents, interested parties? Okay, good. All right. So, look, I wanted to talk to you about a couple of, what I see as a couple of paradoxes here about in the developed world, we spend a lot of time trying to help people lose weight and develop health. And in the developing world, there's a huge paradox because the developing world contains some of our biggest problems in terms of inappropriate nutrition and perhaps even worse than that, maldistribution of nutrition. So I wanted to talk to you about a few things. We're going to start in the developed world first and show how we help look after people with weight-related health problems. Then we're going to go and look at some data on that and then look at the developing world, and then finally wrap up with a couple of really nice slides about how our faculty is one of the best around, as you'd expect. Now, professors are they're kind of like normal people. They're kind of like mums and dads everywhere. They have different jobs. We wear academic gowns from time to time for official events, not like in Hogwarts where they have to wear their gowns every day. We only get to wear ours for official events. Anyway, at Hogwarts, everyone's a professor. Here, only a very few people are professors. Obesity is a medical term. It means excessive fat accumulation, and to the point that it might present a risk to health. And I know that there's all sorts of pejorative terms around obesity and being fat, but if we look at it medically, we can get through it without offending too much of our population. And when we look at how to measure this, and that's probably the most important thing, is getting data on board first. We've got a few different ways of using it. The body mass index, or known as BMI, is possibly the easiest one to use because I think many of you will know it includes using weight and height. So if we take the weight in kilograms over the height squared, we get this range, and the normal range is meant to be 18 to 25 or so. I've got to say that's a little outdated, that range, because it was developed in the 80s from recruits to the American Army, and it's been used ever since. It's probably inappropriate. Probably in Australia we should be looking at 20 to 27.5 or thereabouts in terms of an index of health. Nonetheless, that's what we use, and there's a lot of data around this, and even though it's probably occasionally inappropriate and should never be used in isolation, it's really easy to use because people's height doesn't change too much, and we can monitor their weight by weighing people. Just to show you how inaccurate it can be, Arnold Schwarzenegger, when he was at his peak, was probably packing a BMI of around 45. And whether or not he was healthy is another issue, but it doesn't take into the build into account. Nonetheless, it's kind of useful. Another way of looking at it is by performing a scan, and this is called a DEXA scan. It's an X-ray densitometry style of scan, and it shows us fat distribution through the body. And this is really accurate, but these cost money. The scanning machines are pretty expensive, and these around Perth, these will cost up to $110 to perform. And so, as a population tool, it's wholly inappropriate. And we use it for research purposes quite liberally, I must say. Other scoring methods, something really simple like the waist circumference is really accurate, and even more accurate is the ratio of waist to hip to neck. So these are various indices that are measured. And I've got to say, I'm a surgeon out there in the real world practicing. We practice forever, by the way. Anyway, so we measure these on all of our patients and keep track of these data. We don't just use weight as the index of our patients' ill health and the like. So there are a variety of risk scores available depending on history, but most important is, are we concerned about weight because it's a driver for illness? And that's what we concentrate on. Sadly, as the weight increases, and this is again against BMI, the risk of dying, so this is a mortality ratio, 2.5 times the risk of dying once you get to a body mass index of 40. And that's really scary. So what is it? What are the illnesses that we develop? Just about every system can be affected. And when you think about people who are carrying too much weight, there are mechanical issues about that. So what we talk about with mechanical issues is overloading joints, making it too hard because there's too much weight on board, too hard to breathe, too hard for the pump, the heart as a pump, too hard for the heart to pump blood through various tissues. There are metabolic effects associated with fat. We thought fat was kind of harmless for many years, but we do know that metabolically it's very active, and it does elaborate hormones called adipokines into the system, and they might be metabolically active, but they're also active from an inflammatory point of view. So we find that people who are overweight have a higher rate of inflammatory conditions such as rheumatoid arthritis, psoriatic arthritis, and a whole heap of these systemic illnesses that we used to see infrequently, but are now seeing a lot more frequently. Part of the metabolic effect is and I think many people know this, is the risk of type 2 diabetes increases significantly with weight, such that if you're a woman and have a BMI of 40, you're possibly 12 times more likely to have type 2 diabetes than your healthy weight counterpart. And I've got to say, that's a really scary factor. One of the other effects with hormones is increase in the risk of various cancers. So endometrial cancer means a cancer of the lining of the uterus, and that's increased significantly in women who are overweight. Look, every system is at risk of an illness because of increased fat load in the body. Are they going to kill us? Well, everyone's really worried about ISIS and terrorists now, and that's where we put them. This is the causes of death in perspective currently. This is data out of the National Health Service in the UK. This is war and terrorism up here. Heart disease, cancer, respiratory disease, digestive disorders, diabetes is here. Being overweight plays a role in just about every one of these. So being overweight has now taken over from smoking as the number one preventative health problem in our community. And I've got to say, that's a bit scary because it's sort of within our control. And if you look at the projections, they're not really nice. These are projections done by the World Health Organization out to 2025. We're not slowing down anytime soon. So if we look at Australia, why are we getting bigger? Well, we kind of live in this now culture, don't we? That if we haven't had a chance to prepare a meal, we'll dial up a pizza. And I don't know about most of them, but I know Domino's run at about 40% fat, and that's just scary. We don't like waiting for things anymore. I want it now. If I exercise, I expect to lose weight today rather than over the next 3 months. I don't think that you need to be reminded that Australians drink too much and that alcohol is really high in calories. And we certainly exercise as a nation a lot less than we did previously, a significant amount less. So we are aware that perhaps 70% of Australians do little or no exercise. And that's a bit scary because we used to be quite a sporting nation. We still compete very well on the world stage from a sport point of view, but the majority of us don't engage in that, apart from watching. Confusion. Every time I open a magazine or a newspaper or go online, I see someone else trying to say there's another diet on the horizon, whether it's paleo or is it the 5 and 2, there's the carbohydrate diets, the CSIRO diets, there's a whole heap of diets which are said to deliver, and each of them are really, they're all quite different. By the way, none of them are very sustainable, and we don't have good data to support most of them in terms of result. And it can be quite frankly confusing if you're a consumer and want some advice on how to lose weight. Fearing change becomes an issue. Do we really want to change our lifestyle, or do we remain comfortable the way we are? We're waiting. I know I can't wait for that gene technology or the tablet that means I can stop operating on overweight people. Curious for a surgeon to say he doesn't, I'm prepared to stop operating on overweight people, but we're all looking for that technology that fixes everything for us, the magic bullet. We live in a very affluent society. America, our television programs are streamed immediately from America. We used to be an isolated island where we could get on with things, but now we tend to follow America's cultural changes. So the donut place that opened recently was sold out within seconds. It's scary that people are attracted to a culture that outwardly doesn't look too healthy. So Australia has changed over the course of the last 3 decades. We drink more soft drinks by a factor of 2.5. Our portion size, our fat content in fast foods has gone up. Our portion sizes have gone up. Everything is bigger, and you're aware of these various things like Super Size Me, those sorts of programs out there. Well, it's certainly happening. So, how do we treat? If you're looking for evidence, and when we're scientific practitioners, which we espouse to do at a university like this, we're looking for evidence for what we have. And so if you're overweight as an adult, you probably tend to engage in this sort of activity. Portion control. There are lots of meal replacement therapies out there where you actually forego eating and have a low-calorie shake instead. Diet and exercise is important. There are a variety of medications with some new ones on the horizon. But if you have, and which many of my patients do, are 50 to 60 kilograms overweight, then these sorts of activities are really just, they're just treading water, and we're in the shallows with them. If you have a major weight problem, then surgery is what's necessary. And surgery is the only treatment that has been reliably found to reduce fat burden in patients who are morbidly obese or have clinically severe obesity.
Excuse me.
Hello. Yes, so I'll go through some of the operations shortly, but this data shows gastric banding here. Previous non-adjustable gastric banding. The really biggest fellow is the biliopancreatic bypass, which is rarely done in Australia, and the standard gastric bypass here. So these are operations which we know reliably deliver 30 to 50 kilograms of weight loss. And I'll go through those now because this is what I spend a lot of time doing. We don't consider patients for surgery unless they've been through a really elaborate assessment and workup involving the patient in a patient-centred plan with a surgeon, a physician, dietitian, psychologist and exercise physiologist. So we look at trying to address our patients' care from a variety of different directions and try to be really quite holistic in it. So the surgeon tends to be leading these activities. There's a variety of different operations around, and each of them is different in what it delivers and the suitability for various patients. So we need to select the surgery and of course be skilled in doing the surgery, and then supervising long-term follow-up is extremely important. One of the things that we do need to appreciate is that being overweight or having obesity-related health problems is a chronic disease, and it needs to be treated in the longer term. So we never ever discharge our patients. We hang on to them and ask for them to come back and see us in our clinic for life. We use a primary care physician, so a GP with an interest in these problems, whose job it is to help us prepare patients, but also then follow them up in expert fashion. Our dietitians, really help patients understand about healthy lifestyles. And the other thing to appreciate is that patients, if they overeat, which many of them do, they have no trouble getting all the macro and micronutrients that you need. So the vitamins and minerals, if you're eating a portion size like that, it's really easy to get all the vitamins and minerals you need, and the balance of carbohydrate, fat and protein and the like. But and surgery is generally based on patients being able to eat less afterwards, so getting the micro and macronutrient needs provided with a smaller portion size is something where dietitians become involved. And so, and helping retrain patients in healthier eating patterns, because many of our patients sadly have kind of chaotic eating styles. And this is a big one in our society. It's the concept of patients requiring psychological support. And many of them are depressed and have other mental health disorders requiring full support. As the weight comes off, concerns about body image may arise, and close follow-up with our psychologists is extremely important. It's kind of sad that we used to be an exercising nation, and now we need to be coached on how to exercise. And our biggest desire is not to have people working in gyms and in gyms, but is to exercise with a buddy in the real world, and that's what we're really looking for. Anyway, so for us to successfully operate on patients, and this field of surgery is called bariatric surgery, we do need our patients engaged. We do need to have them cared for in a complete way and engaged in long-term follow-up. This is the adjustable gastric band you mentioned, and there have been many thousands of these put in around the world. Australia and Europe have led the world in this operation, and basically it works around having a small pouch above a restrictive band, a small pouch here that allows patients to eat around 2/3 to 3/4 of a cup at a meal, and a normal diet is generally tolerated well, and weight loss is fantastic and satisfactory, meeting our medical needs. This is a very popular operation around. Now it's called the sleeve gastrectomy, and if you can imagine removing this much stomach, leaving the stomach here with a capacity of about 150 mils. It's a major procedure, and it's not without its concerns, but it's very successful and it's very popular. And I have to say, patients lose weight really quickly, and you can imagine why they do when this is how much of the stomach is actually removed. That's distended with some fluid afterwards to show you how distensible the stomach actually is. So that's gone forever. The other operation that is performed here and elsewhere is called a bypass. Really briefly, the stomach up here is divided with a small pouch, and that's hooked onto a loop of bowel, and the food coming in is bypassed down into the bowel beyond the stomach, so the opportunity to absorb nutrients is reduced. It's a big operation. It's certainly bigger than the previous gastrectomy. It's done as a primary operation sometimes, but most often in this country it's done as a salvage procedure following other surgery if it becomes necessary. And here's an example of a patient who had a previous gastrectomy, a previous sleeve gastrectomy, and this is the esophagus, the gastroesophageal junction, some stretching up of the top half of the sleeve because of some excessive scar tissue here. And that's a patient who would require a salvage procedure as a bypass. The good news is surgery works, and surgery works really well. And we've got good data to show that there's significant improvement in every one of the problems that being overweight brings with surgery and with weight loss. And so really staggeringly good results with a 90% reduction in projected mortality. So the risk of dying is reduced significantly. What I find most engaging about my patients is that their health-related quality of life scores improve. So we do lots of studies on patients to see how they improve in their well-being, and in every parameter they feel better after surgery. and it lasts well. This is a very famous study, the SOS trial out of Sweden. The Scandinavian countries have really, really good tracking of their health results. Our patients can be followed up with, in intense ways for years, and they're a very cooperative race of people, I must say. And this shows the 20-year results out from control, which means being looked after medically by your GP, versus a variety of different operations. But the good news is that there's daylight here, and all of this surgery works, and it works out to 20 years with substantial reduction in weight and the associated medical problems that go with it. And many people say, hang on, surgery is a really big deal. Is it safe? And the answer is yes, it is. So here's registry from Australia, where we have what's called a bariatric surgery registry, where most of the surgeons in Australia are participating. And you can see some pretty big numbers here, looking at 23,000 procedures. And I have to say, we're not talking about this today, but it's kind of sad that 86% of the surgical activity takes place in the private sector. And whereas it's really needed in the public sector, and that's for our politicians to help us work through. And of the patients who have surgery, 96% of them engage and are prepared to be involved in the registry, which is great. I talked about this being a chronic disease model, being overweight and having treatment as a chronic disease model. 70% of our procedures are primary, which means that 30% they've had a previous operation. And that's something that the public has to be aware of as we look after them. Now, how safe is it? Well, out of 12,800 operations, there was an adverse event in 2%. So 98 or 97.8% of patients got through without any concerns at all. The risk goes up a bit if they've had a previous operation. And people think they're going to die having an operation. Our mortality rate, or so the death rate related to the procedure, is 0.02%. This is extremely safe surgery. And by the way, it's pretty popular as well. This is data over a 10-year period. I'll just walk you through this from 2003 through to 2013 at 4 different time points. And the overall number of bariatric operations around the world went from 146 up to 470,000 procedures around the world. That's a staggering increase. If we look at our region, this is the proportion within our region, and it's just interesting when we look at various things. This is the gastric band, which used to be the gold standard in Australia. It's almost as if it fell off a really steep hill, and that's most unfortunate, because I find gastric bands very useful in cooperative patients. At the same time, the sleeve gastrectomy has virtually exploded in this country and around the world as well. The bypass is becoming more popular as well. So if you look at a surgeon's list now who does this sort of operating, then you'll find that sleeve gastrectomy represents most of the cases. There's the occasional band and the occasional bypass as well. They're the 3 major operations we're doing in this country these days. Now, we do keep track of our data, and this is from a report that came out 3 weeks ago from the Australian Institute of Health and Wellbeing. Just to pick the eyes out of it for you, we know that 63% of Australians, adult Australians, are overweight or obese, and roughly 23,000 operations are done per year, and of those, roughly 80% are primary procedures, and 9.7 people out of 10,000 are having surgery. That's only 0.1%. So 0.17% if you happen to be in Western Australia, where people are worried that we're doing more than elsewhere. And so you'd say, and these are the people having surgery, that it tends to be women in this age group, and it tends to be men 10 years later. And you say, oh, well, that's when you look at the numbers, it's way too much surgery taking place. But if you look at it in context, the amount of bariatric surgery done is really only the tip of the iceberg. So it's as I said, 0.17% in Western Australia. I'll take you back to the risk associated with being overweight, and we'll say that's really terrible. But what about that and age? Because this is across all adults. And some data came out about 10 years ago that suggested that older people could tolerate being overweight a little better. And we talk about the obesity paradox in those, and it's got a lot of press, I must say, and sadly, probably more than it deserves. And this is what I mean, that if you look at the audience, I'm pretty sure we're all in this age group here, the red group, where as you look at mortality risk over the body mass index of 35, but if you happen to be over 70, it apparently is better tolerated. And this is where some writers got a hold of this, and medical writers got a hold of this and said don't lose weight over the age of 70 because it's safer. There is a phenomenon that we know where people over the age of 70, if they lose weight because of an illness, they tend not to regain it, and it tends to be a negative factor, and people gradually fade away from 70 onwards if they've got medical problems. But what this data didn't take into account was whether or not the weight loss was intentional. And the other thing is that the data collection was probably not as robust as it could have been, and most of our data comes from telephone calls to people. And I've got to say, if I get rung up at 6:30 at night and someone says, "What's your weight?" I'm going to go for an ideal weight, I reckon. But it's just that the modalities of data collection are not as robust as we'd like to think. So using fancy parabolic graphs like this doesn't always give us the real picture. So it's been revised this year through some work at Harvard in Boston, which suggests actually being overweight is still a problem if you're 70. Given that if you're 70, you're probably going to live to 85 or thereabouts, or 80 thereabouts, we're not sure how much energy and resources should be put into someone who is compared to someone of age 25 with the same medical profile, perhaps. Anyway, it's just we do, where there's limited resources, we need to think about how to apportion those resources adequately. And I have to say, we get our patients liberally engaged in these sorts of decisions. This is the other thing we hear about, and that's how do we feed the world? I'm sure you could name the countries that are in the crimson or is it dark red, where there's undernourishment in excess of 35% of the population. We know that's not a very nice place to live at the moment. North Korea, what's that? Is that Yemen, I think, and Central Africa, Mauritius and the like. So various places we know about. But let's concentrate on this guy for a moment. These are our two most populous countries, aren't they? China and India. Let's go to India for a bit and talk about diabesity. So diabesity means diabetes developing as a result of being obese. And there are 1 in 12 people have diabetes now, and half of them don't know they have it. And a person dies as a result of diabetes every 7 seconds. These are staggering statistics. It's a big bad guy. And if we go to India, where we can, because of the reduced fat to muscle ratios, and because of the diet rich in carbohydrates, ghee, clarified butter and the like, there's a strong link between diabetes and obesity. And there are 65 million patients in India with diabetes, projected out in the next 15 years to increase by 60% from that. These are huge numbers, and there's lots of them. And staggeringly, it's the 40 to 60 age epoch where most of these people are affected, and it costs them a lot. 1 million rupiah is a crore, and so the equivalent is $7 billion in terms of the cost of diabetes care in India. If we move over a little bit to the to the east, in China, to have obesity go from 5% to 25% in 10 years is really scary, really, really scary. And if you look to the causes behind this, in the developed world, being overweight is associated with lower socioeconomic classes. In the developing world, China, for example, is considered part of being affluent, is the ability to eat fast food when you want it. Screen time, these are all documented, that the increased risk of obesity is associated with all of these factors: the explosion of fast food, screen time and TV time. The little emperor syndrome, so if you only have one child, how's it go? Asuba, is that 2, 4, 8? So 2 parents, 4 grandparents, 8 great-grandparents, that with one child to focus on. They're special. And of course, when people are special, we like to feed them. Part of being around celebration is almost always to do with food or putting something in our mouths. I visited China a year after Tiananmen Square events, and this is how China looked then. It looks vastly different now. At the same time, there's increase in smog, so air pollution correlates with obesity. Maternal obesity correlates with childhood obesity, and that's certainly going up in China at the moment. Maternal recognition of obesity is important as well. So if a mother recognises that a child is overweight, then we're inclined to do something about it. But if you don't recognise it, and there is under-recognition in many of these developing or developed countries as well. China, in fact, if you look really closely, you can see China's here, or New Zealand is here. Shame on you. Greece is way out here. Australia's here. Everywhere. And so if we're saying, look, a percentage of our children overweight and obese, we really should be looking at below 10%. But all of these nations, this is going to be your problem, not mine, okay? I've got enough work to do, but you guys have got more work to do by the looks. Okay, so what can we do about it? Boy, oh boy, what a photo opportunity with Michelle Obama on the White House lawn. If you look at those kids, none of them are overweight. So it was just a great photo op for them, increasing physical activity in the States. But there's lots and lots of different things we can do. And in Australia, we've got really robust guidelines and directions for health practitioners on how to help and encourage healthy weight in Australia, for example. And of all the things that we can do, this is probably the most important, actually documenting and measuring it. And I wonder how many of you have been weighed when you go in to see your doctor, or weighed when you go to see a community nurse. I have to say, when I go see my doctor, I expect to be weighed, and it doesn't happen that often. But we can look at various strategies at the local or community and national and international level. And I've got to say, it's all about awareness and multi-pronged attacks. We did it with smoking. And Australia has led the world in reduction of smoking through various community-based strategies, and one other that I'll talk about at the end. But we can do really well by reducing smoking. We should be able to help with obesity as well. With preventive activities through World Health Organisation has lots of promotions. Here's one that WHO funded in around Geelong, Romp and Chomp. You've seen the various programs, that the 2 and 5 promotion, and I have to say, this is probably one that's going to help the most is taxing sugar. I know it's a dirty word, and if you want to lose government, you put up a new tax, of course. So this is one there's quite a bit of tension between health practitioners and politicians. Let's move on. If you want to come and be a medical student at UWA, you'll smile. You'll smile all the time. We've got a lovely library. We've been around for a long time, and we have a lot of fun. We get really good results. And I've got to say, as a community doctor, as a community specialist, my interns, the interns who come to me from UWA, I know exactly how they're going to behave, and they behave exceptionally well, and that's fantastic. We have a... This centre is called CTEC. It's a simulation centre. Okay. So the role of simulation in medical education is all about reducing the learning curve, giving students the opportunity to practice in a safe environment under the supervision of people who really want to teach them. We have, I think, 320 intern placements in Western Australia each year. So we know that the graduates from our medical school are going to get good quality jobs in a well-supervised, supportive environment. Sorry about that. We didn't do a sound check. That's on YouTube. Look me up on YouTube. No, we run part of our medical school is we run a facility here. It's just 200 metres away, where we run courses for postgraduates, so surgeons in training, and all sorts of other doctors. There's a gynecology workshop on there today, advanced gynecology, and our medical students get to come through this workshop place as well. It's called CTEC, and medical students here, and actually most medical practitioners around Western Australia know about CTEC and know about our activity. As far as simulation goes, it's combined medical and surgical simulation, and it's the busiest surgical simulation facility in the world by a factor of 2. So we're twice as busy as anywhere else in the world, and it's supported by the university and also by the Department of Health here. So it's a really wonderful place, and our students love coming there and doing courses with us. Enough of me. I wonder if there are any other questions. Otherwise, I hope you enjoy the rest of your day. Thank you.
Hello.
Hi.
So I was wondering, between the different bariatric operations, is there one, or is there like a kind of ranking in which of them is more effective long term?
Okay. The really interesting thing is that each of these operations works in a different way, and we should help patients choose an operation based on their particular needs, based on their lifestyle, and based on what they're up to. So if I've got someone who's maybe 30 kilograms overweight, who lives in the metropolitan area and who seems highly motivated and reliable, I'll talk to them about a gastric band, because you need all of those factors in place for that to work for them. If I've got someone who flies out every 2 weeks to a mine site, then the safest operation I can do that for them is a sleeve gastrectomy. And as I said, bypass is really good for severe diabetes because it's got a fantastic metabolic effect. It's also good for severe reflux, but I know the patients have to be able to contact me straight away because there are certain risks associated with it, like internal hernia, so bowel obstruction that can occur after a bypass, and that can happen any day. So patients, we need to gauge their reliability, and there are various operations we can do to help them. So there's no single operation that suits everyone, not by any means.
And is there like an optimal age group?
Oh, look, we really need to. I have very few patients under the age of 18. And if they're under the age of 18, we talk to them and their families long and hard, and I will only see them if they've been through a program at Princess Margaret Hospital, which is one of the best 2 in Australia in terms of adolescent programs. So yes, we do have a lower age limit where we talk to them long and hard. Patients between 60 and 70, we talk to them at some length about values and what they stand to gain. We operate on very few patients over the age of 70. But the other thing is, hey, what if my BMI is 35? I've got medical problems, that's fair enough. What if it's 34 and 33? And so we look at in a very flexible way at all of these patients.
Hi, quick question. So I was just a little bit curious as to why the proportion of women getting gastric banding.
People, sorry?
The proportion of women. So there was a slide that said 80% of the patients receiving this kind of surgery were women, and I was just curious.
Why do 4 women for every 1 man have the operation when we know that the fat distribution is equal across Australia's society. You've got to want it, you've got to need it, and you've got to be health aware. Australian males, I paid for this. I've earned it. Health awareness is 4 times greater amongst women than men. Look, they'll blame work requirements, employment opportunities, but no, it's all about health awareness. We don't select. We will only operate on people who really, really want surgery, and so they're Aussie males. They're crap. They're not good.
My question was, how, you've got all this data. How are you going to sort of tackle the media side of things? So there's a number of factors here in terms of, for example, kids always being shown McDonald's, and also in the media now it's like inappropriate to use the F word. Fat. Right. So like you're not even, that I think would be a huge hurdle, because you'd see people and you say you're overweight, they're like, oh, you can't call me fat, it's normal, you like. Sure. And the other issue of like representation as well, like the shifting baseline. If people see American, you talked about the American influence, and the new normal becomes overweight because people just see overweight people. Yeah,
that's exactly right. And look, we have to try and translate this into health-related quality of life. And there's always going to be an element that says this is the new norm. And but at the same time, we lobby government, we lobby health departments, and we're seeking to work out how to lobby the community better as well. I use fat as a noun, not an adjective, and I absolutely understand the pejorative thinking around various terms. So we no longer like using the term morbid obesity, because morbid means death, of course, and that's not right. It's health-related, clinically severe obesity. So you've hit this on the head, and one of the concerns that we have, or I have, because I sit on a number of national boards around this, is health promotion, and there are far better people than I am relating to health promotion. You've seen the toxic fat ads? Yeah, they were my patients. So I filmed the camera work for that was mine at surgery. And I think that's done really well. It's really out there, and I think that's been really well used, and that's by the Heart Foundation. At the same time, I think there's going to have to be a sugar tax. There's going to have to be a calorie tax somewhere, just like we've taxed cigarettes out of them. Every time the tax goes up on cigarettes, another bunch of people stop smoking. So, for better or for worse, we've got to make it too expensive to be fat as well. Look, but educational promotion is really important. That if I'm home late, I don't tend to to heat something up. I'll tend to make a salad for myself and throw some tuna in. It's more work, but I'm health conscious, and it's all about engaging and trying to tear down the dollar input from fast foods. Because like it or not, those guys earn a lot of money, more money than we'll ever have to throw against it. So we've got to promote health over shiny calories. I don't have all the answers there. I'm a surgeon. I just operate.
So apart from bariatric surgery, like for overweight and obese, yeah. Well, so mainly for obese people, is there any kind of evidence-based thing that works?
Oh, look, you're talking about lifestyle correction.
Yeah.
And I have to, please be aware, we will never operate on someone who's got a chaotic lifestyle. So our patients have to engage in lifestyle correction first. And I've got to say, most of the time when they come and see us, we'll say, okay, your weight today is here. We'll operate when you bring it down to there and show stability. So our patients have to do all of that first, because there's no operation that can't be defeated by behaviour. And, we talk about biological set points that are the weight that our body wants us to be. our body will do anything to defeat our weight control strategies.
Just on that point, sorry.
Yeah.
How, when you say bringing down the weight, would that typically be like 3 months you're looking for the lifestyle changes, or what?
Generally, 6 to 12 weeks, and it's generally in patients, it's generally to demonstrate their commitment to lifestyle change. And then if they've had a chaotic past, then we'll generally ask them to go for a bit longer to demonstrate sustainable commitment. But I gotta say, the results of surgery is so good that our patients will do just about anything to satisfy my criteria for admission. But the other thing is that there are some patients who sadly are just too big for the system. And most hospitals have a cut-off point at 180 kilograms. So they won't allow patients in over that point. So we need to work with them to bring it down. And that's actually kind of a positive thing as well, because preoperative weight loss predicts post-operative success. That's good. Thank you very much. Well done.